Okay, we're gonna get started, everybody. I just wanted to do some quick information before we start. So to let you know, we have a number of programs joining us, and we are doing the Zoom through Kapiolani Medical Center on Oahu. We have children with special health needs programs joining us, early intervention programs statewide that are joining us from their locations and sites throughout the island and neighbor islands, and some additional participants as well, Rehab as well. So we wanted to just do a quick thank you to everybody who made today possible. There was a lot of planning and preparation. So just a quick thank you to the Department of Health Genomics section, the Kapiolani Cleft and Craniofacial Center staff, Hawaii Pacific Health, the Department of Health Children with Special Health Needs, as well as Department of Health Early Intervention section. So with that, we'll keep it short. Our presenters today come from the Kapiolani Medical Center, Cleft and Craniofacial Center. I'll have them introduce themselves as well as what they brought with them. We'll do our best to make sure that everybody can hear clearly. If you do have questions throughout the presentation, please put them into the chat. Because all of the participants are muted, so we are not able to hear any of your audio. So all questions do need to come from the chat. We will go through the questions at the end of the presentation. This presentation will also be recorded so that it can be shared with early intervention programs and all of our partners. Okay, with that said, I'll turn it over to Jamie.
You can sit with me. I don't want to be alone. Hi, everyone. I'm Cecily. I'm one of the speech pathologists at Kapiolani. And this is Jamie. She's also from speech, and we're lucky to work with the Cleft and Craniofacial Clinic team here at Kapiolani. So thank you for joining us, and special thanks to Eileen for helping us get this set up. It's kind of exciting to be able to share about what we do and then also learn about what you're doing so that we can make the continuum of care better for our patients, because we send our patients out into the community and we really rely on all of you to help coordinate their care and give them their therapy services. We're just one little part of the whole thing, so we appreciate your time. Today we want to go over what our clinic is, what our involvement in the clinic is, so that you kind of have an idea of what we're doing and where we're coming from. And then we'll talk about the different diagnoses that we deal with, surgeries, some feeding stuff, and a little bit of speech therapy too. Okay, so first of all, if you see the acronym KCCC, it stands for Kapiolani Cleft and Craniofacial Center. That's the title that will show up on our reports or paperwork, and so you'll know that that means that patient came through the Cleft clinic for that day. That's the website that you can go to that has information about like how to refer and what our team is made up of, and just different information about the working parts. The referral, or you can call the number that's under the contact information if you have questions about a patient, or if you want to know how to refer, or if you're just looking for a team member and you can't figure out how to get in touch with them. That's a good number to start with. I think that's fair, right? Yeah. And then, am I hitting enter or this one? Okay. So, oh yeah, because I was already on that one. Okay, sorry. So it's figuring out how to use this. Can it go back? Okay. Okay. So the Cleft team here is approved by the American Cleft Palate and Craniofacial Association. I put the website on this slide for you, and I was just actually looking at it again, and I realized that the cleftline.org, it's a standing alone website, but the two groups have actually kind of merged together, so you'll link quickly to both of them, and they're now being called the ACPA Family Services. The Cleft Palate Foundation is now being called ACPA Family Services. So ACPA is the group that is a big national body for all of the different providers that provide service for patients with cleft palate or craniofacial anomalies. So all the doctors and other medical professionals, nursing care, therapists, audiologists, all those people that have their hands in their care. And then the Cleft Palate Foundation was kind of more family-based, which is why they're now ACPA Family Services. So that's a good site to go to send your parents to if they have questions about what to expect or just kind of want some support for what they're experiencing, to find some support from other people who have gone through it. The approval on the website will say that doesn't necessarily say who's the best qualified, but it is saying just that we meet the standards in terms of the makeup of the team and the type of care that we're providing. Okay, so on a cleft team or a cleft and craniofacial team, you'll see a number of professionals. On our team, we have an audiologist who does the hearing screening or the hearing assessments and coordinates with the ENTs and the other surgeons as far as what types of procedures might help the patient with their hearing. We have the behavioral health nurse practitioner that meets with the families in case there's, because there can be a lot of stress and emotional needs, and we want to make sure that they're taking care of all around, you know, medical stuff, health stuff, and definitely their mental and emotional health. So our craniofacial surgeons, I'll just kind of quickly read it. The genetics and genetic counselors come in and meet with them. The ENTs come in, oral surgeons, orthodontists, there's pediatric dentists, our plastic surgeons. And then in our team, the plastic surgeons are doing the repairs and any secondary surgeries to the palate. There are some teams across the nation where the ENT might do some of the surgeries, so just kind of a piece of information just to know about. But in our team, the plastic surgeons do the repairs. We have pediatricians and a nurse practitioner who meets with them to kind of coordinate care and manage like the basic health and kinds of things like that. We have a social worker who helps with community resources and helping them be able to, like, working out getting to and from appointments, and then speech pathologist. And like I said, I'll go over what our role is in a little bit. Okay. So in our clinic, we service a number of different diagnoses. So this is just a quick list of the different ones that we see very commonly. Yeah, so we're gonna actually have Helen, who's our pediatric nurse practitioner and a really, really important part of our team who coordinates all of us. She's gonna go over these really great skulls that we have. Okay, I'm gonna.
So I think you were kind of going through this slide, so while you're going through the slide, I can do the skull. So I'm Helen Lau, the nurse practitioner with the center. Thank you so much for joining us today and for inviting me to this talk. I just looked at the PowerPoint and it just looks amazing, so I'm excited to hear the rest of it. So I wanted to show you, these are not cadaver skulls. I'm sure the, oh.
Oh.
No, that's good.
Okay, so this is our normal skull. I don't know if this is zoomed in enough, but you could see that this is a normal infant skull. This is not cadaver. This is all fake material. But you can kind of see the alignment of the jaw. This is what we would anticipate in a normal infant. For children who have our cleft, this would be a unilateral cleft lip and cleft palate. You could see that there's a gap in the upper jaw here. And then when you look in, there is also a bony defect through the palate portion. And so these are some of the skulls that we share with families when they come in, so they can have a better understanding of what's happening anatomically to the infant. So this is a bilateral cleft lip and cleft palate. You can see that there's bony defects through on both sides of the upper jaw. Also wanted to share with you, you probably get a lot of referrals for patients with PRO band. And so what that really means is PRO band is a sequence So you have a few things that you would see on clinical exam. You would see that the baby would have a smaller lower jaw, and this can affect breathing and eating. Many times the babies also have a cleft of the soft palate, and as well as glossoptosis, which just means the tongue tends to hang out and it's a bit larger. And so all of those things can affect airway and feeding. And I think Jamie wanted me to also bring up our Treacher-Collins syndrome. So you can kind of see the difference when you look at the two skulls, anatomically the difference and how that can affect feeding and breathing and eating. Okay, so those are the different skulls. I don't know if we're able to go back to the previous slide and we can review quickly over. Do I just click?
Share screen.
Oh, just click on. Oh, okay. Right here.
Double click. Oh, share screen.
Okay. And resume. Okay. All right. So these are so some of the diagnoses that we see in clinic include cleft lip and cleft palate, the cleft of the soft palate, submucous cleft. We also take in referrals for VPI, 22q11.2 deletion, Pierrot band. We just saw a skull for Pierrot band, microtia, which is underdeveloped ears, craniosynostosis, Cruzon's, which is a syndromic form of craniosynostosis, and also hemifacial microsomia, plagiocephaly, Treacher-Collins, and Pfeiffer. So if you ever have questions on patients and you think that you may be working with a child who may have certain symptoms and you want to refer them to team, please go ahead and contact us. You'll probably either reach me on that number or Liesel, who is our coordinator with the Cleft Clinic. So that's it. Is there anything else you want? I'm going to leave this here.
Thank you. So just a quick, I just think that most of the slides that we have going forward are a little bit focused more on cleft palate, soft, cleft of the soft palate, submucous, so those kids with velopharyngeal dysfunction, or VPD, sometimes people are calling it VPI. I won't talk about that for this presentation, but because it's kind of specific to the speech staff. So as far as like for the microtia kids, we see them to help keep track of their speech and language development, and then make referrals or suggestions to the family in terms of if we think they need more services or just services in general. And then that list that's on the right side of the slides has different syndromes, and it's kind of, we evaluate them in terms of, do they have any problems with their speech and resonance, and then also looking at language, again, so that we can support the family in making recommendations or referrals if we think that they need them because they don't have them in place, or if they just have more questions for us. Okay, so the speech therapist involvement in clinic. So we see all of the patients that come through that need speech evaluations, and we typically see them on our Cleft clinic days, which are Fridays right now. And we also participate in the conferences that we have twice a month, where we get together with the different medical professionals that are on the team and talk about their medical needs, their social needs, and anything that will help them be able to participate in school or family life. So it's a lot of collaborating in that conference and figuring out the plan of care for them. We also use our findings to help participate in surgical recommendations for surgery or versus therapy, and kind of like map out timelines and figure out what the next move would be for these kids. And then we also offer recommendations for services or community referrals that we think might be appropriate when we're meeting with the families. So a little bit, oh no, what did I press? Okay. So a little bit more about the evaluation. We do an annual evaluation, and now we're starting it as early as even 16 months of age. because we're trying to catch their speech as early as possible to provide as much education to the families about what they can work on with their child, or if they're not in services, to help them get services as soon as possible if they need it. And then we do an evaluation annually with the Cleft clinic through at least 6 years of age. And then after that, we go to 2 years, every 2 years through almost through adolescence, or until as long as they need it. And some of our patients will stop seeing for evaluations if they're doing well consistently at each annual, because they don't seem to need speech anymore. And so the reason why we keep them till 6, sometimes even 8 annually, even if they're doing okay, is because there's growth that happens. And we want to make sure that if any change in their anatomy is affecting their speech, that we're catching it as soon as we can. So I'll go over the parts of the evaluation in a little bit. We also evaluate preoperatively and postoperatively. We usually coordinate it with their clinic visits also, so that they can come in and do all of their visits at one time. And hold on, I think that I have that. Let me just make sure I don't skip it. Yeah. So the timeline for the pre-op is just kind of whenever they come in, as close to their evaluation or their procedure, and then or if they need consent. And then post-operatively, we wait for 2 to 3 months to make sure healing is good, and then see how they're doing after their procedure is done. Feeding evaluations are done prior to their repairs, and then therapy as needed prior to, and then after the lip and palate repairs. And we're, like I said, we're going to go over feeding a little bit more. We're going to talk about that, right? Okay, a little bit more in a bit. So at our annual evaluation, everything is done more informally. We don't do standardized tests anymore. We look at their articulation skills. So we have a list of words that we have them either read or repeat after us, that take a quick snapshot of all of the different phonemes that we're looking at in the different positions. And then we look at resonance just by listening to them. So it's all perceptual. We kind of do like a language screener for our microtia kids, and definitely and some of the kids that have other syndromes, and otherwise take it kind of by report, and then also by observations of how they're able to participate in the tasks or just answer questions and engage with us. We ask about current services, and we also ask the parents to bring in the paperwork so that we can just kind of make sure that we're all on the same page. And then if the parents have questions about whether or not group is okay or individual, sorry, that's more school-based, that we can have a discussion with them about why it is or why it isn't, and then make recommendations about what could be changed or modified or added on. We'll ask about feeding, even in the older kids, because some of the kids will still have problems with food or liquid coming up through their nose, and it's good to keep track of what kind of issues they're having. We'll talk about breathing while sleeping, breathing just at rest, because that can, if they're having trouble with breathing, that's something that we have to consider if they're surgical candidates, because you need to breathe to be able to talk and live, so you don't want to compromise that. And then we also do an oral exam. I'm gonna do a share. Oh. Jamie just reminded me to make a point of saying that in the EI population that we work on language, or we evaluate language a little bit more. So recently we've been giving other language screeners or parent questionnaires like the real to get more information about how their language is. Can I show? Okay, what was I saying? Actually, okay. So some of the tools that we use during our evaluations, we have we use our just a flashlight, a simple flashlight, just to get a better view of what's going on in their mouth. And we're looking for any kind of anomalies, if there's fistulas, remaining clefts, and where they are, because those can affect their speech production. This is a little tool, it's called a detail reflector. It's basically a mirror, and we put it under their nose to see the amount of air. You can see the reflection of it. You can see the air coming through, and that's just like another visual tool that we use to gauge what kind of trouble they might be having maintaining air in their mouth when they're speaking. Okay, I'm gonna show you some other things that we use just to show you, since so we don't have to keep bouncing between views, but some of the tools that we use in therapy and even in our evaluations are straws. So straws are great because kids seem to love them. These are really nicely individually wrapped, so it's cleaner. And then we also learned about these kind of fun bendy straws. They've got like a bigger, I don't know if you can see this, like a little, oh yeah, it's a whistle, huh? So this is a whistle, but it's got open ends. I forgot that it was a whistle. You could use it as a straw. And so basically what we're doing with these is putting one end at the end of your opening of your nose, and then the other end by your ear, so that the kids can get some auditory feedback about what their sounds are like. So that they can kind of hear if the sounds are coming, if the air is coming more through their nose versus their mouth. That's all I've got.
There's a question that came up. This is a question. Just curious as to whether there is a particular reason that you stopped doing standardized testing, question, or that you do the resonance testing just perceptually.
So for language or for speech, okay, so sorry, I missed doing this earlier. So the Cleft Day, we have, on a Cleft Friday, we will see, on a Cleft Friday, there could be anywhere from 1 patient to 22 patients that are seeing anywhere from 1 provider to 8, I think would be a good number, 8 providers in one day, in a matter of 3 to 4 hours. So so it can be a busy day when we're at our max capacity. And the reason why we do it this way is so that we can collaborate all together at the end of the day or during the day for a patient that comes in. It just makes everything a little more effective and quicker in terms of figuring out what to offer the family on that day. And then it also is more convenient for the family, so they only have to come to one place on one day, and even though it's for a handful of hours, rather than going to individual visits. But because we are scheduled in this way, our time with the patients isn't as long as we might like it to be sometimes. So part of the reason for having like our word list versus doing a Goldman-Bristow, which is a standardized articulation evaluation, is to focus the assessment a little bit more on what we're looking for specifically for the population that we're assessing. And we don't actually necessarily need that score at that time because we're looking for specific types of errors, and it's easy to gather that information without a standardized exam. So that's the speech production and articulation. Right. Right. So we also are looking at it in connected speech because the sound production can vary a lot from single words, syllables to connected speech to short sentences. So it gives us a little bit more flexibility in terms of like what tools we're using to assess, so we can focus our time on where the errors are happening and figure out specifically what errors they are, and then maybe how to address them to kind of give come up with some therapy techniques quickly. Language testing can take a long time, and since our focus is speech and resonance at that particular visit, we want to make sure to look at it because some of these kids do have language issues, but we also want to reserve our time to focus on the part of their development that we are going to support them with in collaboration with the other medical professionals. That's about right? Which is why for the early interventions, the birth to 3 population, we might focus a little bit more on language because we don't expect them to have quite as many sounds as they would until when they're a little bit older, 2 and 3 or after 3. And then as far as the resonance goes, we actually used to do a more standardized assessment using a nasometer, which is it's a expensive piece of equipment that we hook up to our computer, and it gives us a score based on the airflow. And we used to use that, but it can take a while. And then especially in this age, birth to 3, sometimes these kids are just, it's a little bit scary looking for them. They just don't want to participate. And we've found, and this is actually happening across the nation, that you don't need the nasometer to decide if a patient is hypernasal or hyponasal or within normal. You don't need it to decide if you don't need the standardized assessment to decide if their errors are obligatory or compensatory. I'll go over that vocabulary a little bit later. So we found that not doing the standardized assessments lets us get a more precise or a better assessment of the types of errors and types of the quality of their speech that we're looking for that day. So I hope that answers your question. We can talk about it more at the end. I'm gonna try to go quickly to make sure we have time for the other stuff because I know people are listening in for other things too. So we talked about the annual evaluations. We do pre and post-op evaluations. And so the pre and post-op, we'll look at articulation. At the pre and post-op, we do use the nasometer because we like to have the scores. And then we also talk about whether or not services are needed, and then making recommendations for what types of things to work on. Okay. Sorry, I know I'm talking very quickly. So this is a list of the different tools that we use. I put ears at the very top, and the reason for this is also as a reminder for myself. A few years ago, we had someone come in to consult and collaborate with us about our process and trying to figure out how to improve what we were doing. And he encouraged Jamie and I to trust ourselves and to trust our ears, because our ears are actually a really good tool. So I know that not all of you are speech pathologists, but I think that you can also learn to be aware of the differences in the way that a child sounds and say, that sounds like it's coming out of their nose, or that sounds like they have a cold all the time. And just that descriptive piece of information that you get from listening to a child's speech is almost enough information to say, I think that you should be referred to another type of professional to get some more evaluations to see if you could use some extra services. So trust your ears and your use of descriptive language. They work pretty well most of the time. So we talked about the detail reflector, the flashlights, and the straw. The next two are the oral nasal listener and the Seascape are tools that have been used. I put a picture of this is a Seascape on this slide, and that nub that they're holding up goes into your nose and you're blowing, and then that little white piece goes up and down based on how much air is coming in. So people use that as like visual feedback to show what you're doing with your sound. You can imagine that that's not always the cleanest thing to use and the most fun for kids. Well, it may be fun, but then it'll be distracting. The oral nasal listener looks like a stethoscope with two parts. I don't have the fancy word for this. Two parts that go into your ear. So one goes with the child, and they put that in the ear, and then there's tubing that goes down, and then it connects to another part that you can put into your ear, so you can hear the same thing that they're hearing. And then there's another piece of tube. Sorry, I should have brought this. That connects to those, and we put it under their nose or by their mouth. So sort of like how you would use a straw, but you can keep your distance a little bit better and look at their face. And then you can both hear it at the same time, which is nice for that. So sorry, I did not bring that with me. Maybe I will run and get it when Jamie's talking so you can see it. The nasometer we talked about, and then nasopharyngoscopy. We're really excited about that because we just got a nice new piece of equipment that allows us to do nasopharyngoscopy in the clinic with the ENT and the plastic surgeon, and that is a tool that allows us to see the movement of the palate, which helps us plan better for surgery. Okay. So these are the different types of cleft. A gives you the anatomy of it. I'm just going to let you guys read it, and I guess if people have questions, we can answer them after, since Helen went over the skull. So unilateral meaning just one side of the face, and bilateral meaning both. A and E are clefting of the soft palate. Why does that one look funny? Sorry, B and F is just a cleft of the lip. C and D is clefting of the lip and the hard palate. And then D and H, we would call those complete, because it goes, we would call them complete left and also complete palate. So you can see that that kind of purplish blue color goes all the way from the nostril all the way to the back. The bottom, oh yeah, you can see it. Where the uvula is, that's that back, and so the complete one goes all the way through. For time's sake, I'm not going to go over those anymore, but if you have questions at the end, just enter it and then we can ask them, answer them. Okay, and then these are the types of surgeries that we do. So lip repair will happen pretty quickly. Then there's a palate repair. Those are the first surgeries that happen. If a child has ongoing issues, then they might get a pharyngeal flap or a palatal lengthening. These are some, Z-plasty and furlough are some of the other names you might see in charting. A child might also get a sphincter pharyngoplasty, which is where they take the sides and bring them in. And then, sorry, the pharyngeal flap is where they take some tissue and then connect the palate to the back of the throat to create kind of like a little bridge that helps close up the space that's being left open that makes it difficult for the kids to keep their air in their mouth. And then the palatal lengthening is they're repositioning the muscles to be more anatomically correct, and hopes that it bulks back the tissue so that there's less space between the velum and the back of the throat, and then also hoping that the better muscle alignment will give them better movement. So just as a note, here the surgeons tend to do palate repairs where they seam it all up, and then if they do a secondary repair, then they'll do the palatal lengthening. Some of the reasoning for that is that the size of the mouth when these kids are getting their first repair is so tiny that it's hard to get in to align them. The series of pictures at the bottom series of pictures is kind of a diagram of what the palatal lengthening or the Z-plasty will look like. So you can kind of imagine, like, if you're trying to get in a little tiny mouth and make this zigzag, and then there's 3 layers that they're reattaching individually. It's a tight space to work in. So across the nation, people do different sequence of surgeries, but that's kind of what we're doing here. Okay, so back down to the list, the fistula repairs. So this is, fistulas can come out if the kids are putting things in their mouth and the surgical sites didn't heal well. So they'll go back in to close up that fistula, so just that little hole. And then bone grafting is usually done 7, 8, or even later, because they're waiting for the teeth and the bones to come in. Okay. And then, since we kind of have focused on cleft lip and palate, this is a timeline for when the initial lip repair happens, so before 3 months. And then the cleft repair is ranging from 9 to 14 months, kind of surgeon-based, and then also the health of the baby, because we want them to be healthy and weighty enough to be able to go through a procedure. I think that's kind of self-explanatory, so I'm gonna let Jamie take over and talk about feeding.
There's one question.
Okay.
Palatal lengthening.
Oh, yes. So the palatal lengthening, or like the palatal lengthenings, the pharyngeal flap, the sphincter, pharyngoplasty, those don't happen until usually after the age of 3. And the reason for that is the surgeons, well, us too, we're kind of waiting to see more of the speech, to develop the speech sounds, the articulation to develop, so that we can decide how much of it is, we can decide if the errors are really obligatory or compensatory, and then to also give them time to go through some therapy to see if what their errors are doing are learned and can be addressed through therapy, or not learned, and that they're compensating for that gap that's still open. So after 3 is the short answer, and then you just kind of watch the kids' development and see how they're doing with therapy to decide if they need something else additionally after that. Okay, I'm gonna let Jamie take over. Okay.
Hi, my name is Jamie. Sorry about my voice. I think it's the most horrendous thing in the world when a speech pathologist has laryngitis. You can thank my preschoolers for that. Let me just get to my slides real quick. Okay, so I'm going to talk to you a little bit about feeding. Babies with cleft typically have issues with feeding, more so with cleft palate than with cleft lip, but sometimes also the cleft lip babies do have a little bit of an issue. The different bottles that we use are the Dr. Brown's specialty feeding system, the Magella special needs feeder, which was previously called the Haberman, you might have heard that. The Pigeon, cleft palate nipple, and also squeeze bottles are out there. The Dr. Brown's feeding system, so essentially, this is what it looks like. Essentially, the Dr. Brown's bottle is the same as a regular Dr. Brown's bottle, but it has a one-way valve that's put into the base of the nipple, and it keeps the nipple full of milk, and it creates a compression system. So the babies do not have to suck when they're using the bottle. They have an open cleft, open palate. They're unable to create any kind of pressure or they can't get the intraoral pressure to suck, so they need to be able to do compression to be able to get the milk out of the bottle. See, the baby, with this compression system, the baby is able to control the rate a little bit better. The milk doesn't just flow out without the compressions, as it sometimes does with the regular bottles. One of the pros to having the Dr. Brown's is that it's, because it's the regular Dr. Brown's bottle, you can use any nipple for the Dr. Brown. So it goes all the way from the ultra preemie level to level 4. So it can go really, really slow if the babies are having a hard time with keeping up with the flow, or it can go a lot faster if they're having a difficult time extracting. And so the way this works is, if you're gonna be able to see it, on that thing. So just by me touching the nipple, I'm getting the water everywhere. Just by me touching the nipple, which is what they'd be doing with their tongue, milk is coming out. This is a level 1. So you can see it's kind of fast for being kind of, you know, just a regular flow nipple. So we can go slower to the preemie or the ultra preemie. I'm just going to show you real quick. It's already filled with water, but this is the little valve that goes inside. So otherwise, this is a regular Dr. Brown's bottle, and they just put this valve inside. The bottles are available locally anywhere. Walmart, I think Long's probably carries them, and Babies R Us definitely carries them. But the valves are not available locally. They have to be ordered online, but it is pretty reasonably priced. You can go to Amazon and buy a full set of, I think it comes with 5 bottles, 5 extra nipples, and 4 extra valves, and that's $40. So it's a really good deal for all those bottles. And then if you just need the bottles, you have the extra valves after buying that first set, you need more bottles, or you just need the nipples, you can go to Walmart and just buy those individually, and it's pretty reasonably priced. So the next one is the Medela, or the Haberman. So this one has a much bigger nipple, and it works the same way. There is a valve that separates the nipple from the bottle, a one-way valve, and it turns it into a compression system as well. So all that they have to do is compress on the nipple, and they're getting the milk out. This one, the bottle has a slit instead of a hole, and it has those lines on the nipple. And so when you line up those lines with the middle of baby's mouth, so if you do the short line on the middle of baby's mouth, then the slit is horizontal. And so when you're compressing it, not much milk comes out of it at all. And then if you do it to the middle line, then the slit becomes diagonal and more milk gets compressed out. And then if you do it to the long line, the fast flow, then the line becomes vertical and a whole lot more milk comes out. So I can show you with this bottle, what we do, babies can extract it without priming, but it usually helps them out a little bit if you prime the bottle. So we just turn it upside down, squeeze, and let go, and it fills the nipple with some milk. And then this is on the slow flow. This would be on the medium flow. Thank you. I'm gonna start a fire if I shoot this little phone thing with water, I think. And oh my goodness, I can't get it. Babies can do this a lot easier than I can, apparently. And then this is a fast flow, so medium. There we go, medium, and then fast. So fast is a lot faster. And you can just see every time you compress it, it's refilling from here. The valve opens up and milk comes out. The other things parents can do with this is they can assist babies. So if babies are having a hard time extracting, while the baby's compressing, the parents can kind of squeeze on the nipples to help them get more milk out. But we try to get away from that as soon as possible because it's really hard for parents to try to coordinate. You have to do it together while they're sucking. You can't just like not pay attention and be squeezing. You also have to be careful about how much you're squeezing. A parent once told me that it was the dad. The dad was so funny, but he said that, oh yeah, when he squeezes it, he presses his finger all the way together, and that's how he was feeding her. And I was like, you're making a lot of milk go in her mouth really quickly. And he's like, really? And so I showed him. He was like, oh, that's why she makes that face whenever I squeeze it. Yes, you're shooting the back of her mouth with milk. So, I mean, you really have to be careful with the squeeze. So I try to get parents off of that as soon as possible. And we really want it to be baby directed. So we want the baby to be the one in control and getting the milk out. Let's see. Yeah. So, also, the nipple is available in a mini and a regular size. We don't have the mini one here. I think we only have the regular size, but I think it's available for purchase. Oh, thank you. I did make a mess. Okay, so some of the advantages, like I said, it flows when baby is actively feeding. She's got a parent who's really eager and squeezing that nipple. The nipple shaft is soft, and so sometimes it's easier to get a good seal. It's quite big, so babies who have the cleft lip sometimes have a easier time latching onto it that way. And you can vary the flow rates just with that one nipple. Some of the disadvantages, it can be difficult to assemble, but I don't think any more difficult than the Dr. Brown's, actually maybe a little bit less so, because the Dr. Brown's bottle without the valve has a lot of parts. And then the appearance, I mean, it's got this really long nipple. So we have families who say, you know, my baby already has a cleft lip, people can see it, and they already look so different. Why do I have to give my baby such a big bottle that's going to just call attention to it? So this is really hard for some parents to take in. And then also the families need to be really well trained. Like I said, watching for them to be actively sucking if you're going to be doing the squeezing, watching for, because sometimes the milk will come out just in bursts. So it's not like just any family member can jump in and start feeding the babies with this bottle. It needs to be someone who understands how to use it and understands the lines and everything like that. And also it's quite costly. It's $30 per bottle. Just the nipple all by itself, just this part, is $18 on Amazon. If you want to replace the membrane, which is the little white part. So, sorry. This little white part that comes out right here, this alone is $4.50, and then the disc is $4.50. So, you know, to get this, and this, it's going to be $27 just for this. So you might as well buy a whole new bottle because that's $30. Insurance, if you have Quest, will cover this bottle, but anyone with private insurance like regular HMSA, it's not going to cover. So the families are paying all of that out of pocket. Okay, so if the families who come in who have Quest, and if this is the best bottle system for them, we will make the recommendations and can get a prescription and send it to insurance. So we at the clinic will take care of it to submit for the family so they can get the bottles provided for them, and it gets delivered directly to them, right? Yeah. Okay. Excuse me. So I feel like that's better. Same for pigeon. Okay, so our next bottle is the pigeon. This is the pigeon nipple. Sorry, this is a picture of the old one. The new one is clear. That one was latex, so it's gotten taken off the market. The new one is clear. And there have been some people are saying there have been differences with the clear versus the latex as far as how easy it is to extract the milk. But you don't have a choice anymore, so not really needing to worry about that. But so again, this nipple has a one-way valve. It's a compression system. This nipple has a Y cut in it instead of the slit like the Haberman or the hole like the Dr. Brown's. It's got a Y cut, so the milk is extracted a lot easier. And also it has a thick side and a thin side of the nipple. So sorry. If we take a look at this, can you see it? Sorry. If you take a look at the nipple, I don't know if you can see this, there's a little notch, and that notch needs to line up with the middle of baby's mouth, and then the bottom of the nipple is a lot thinner, a lot softer than the top, and so that makes it easier for baby to extract. So all they have to do is, again, just kind of push on it, and the milk starts flowing. It only comes out when you're compressing. As soon as they stop, then no milk is coming out. But I guess if they're just clamped down on it, the milk is going to continue to flow. So you do have to watch for that to make sure that they're not just holding onto their shooting themselves with milk. This works the same way. You can prime it beforehand. You can turn it upside down, squeeze it, and let the milk flow into it. Although you don't have to. Some babies are able to easily get it out, but some babies just have a hard time with that. So priming it does make it easier for them. And like I said, the little V-shaped vet needs to be facing up towards babies, the middle of their mouth towards their nose, for it to work properly. There is a large nipple and a smaller nipple. I believe this is the larger one. The smaller one tends to be a little bit more in the slower flow. It's not really a slow flow, but it's slower than this one. And then this one is a faster flow. We usually use this for babies who have a hard time extracting the liquid, extracting the milk, and it just helps them be able to get the milk out a little bit easier. It's also got its own little valve. And I think you're supposed to be able to use it on any bottle also, not just the bottle that it comes with. And advantages and disadvantages are pretty similar. Advantages, it flows with active feeding only. It can be used with or without a squeeze bottle. I think the bottle it comes with is a little bit soft, so you can also squeeze it. It's very easy to extract the bolus, and it can be used with any bottle. Disadvantages, you can't buy these on island. You have to order it online or through the 800 number. It is being sold on Amazon now. It does have a higher cost than a regular bottle. It's $10 for just a bottle and $5 extra for the nipples. But the nipple does include a valve. It's not every single piece sold separately like the Haberman. I'm not quite sure why the Haberman is so mean in that sense. But it is a little bit more cost effective. And this one, again, is covered by the Quest insurances, and the clinic can help the families to obtain these bottles through insurance if needed. One of the other downfalls is it is on the faster side, and you cannot adjust the rate. If a baby really can't express milk out of any of the other bottles, this one works best for them, but it is a little bit too fast for them to flow. Then we end up having to do secondary strategies as far as like maybe different positioning, using sideline positioning, or doing pacing with the bottles. The last set of bottles that we can talk about are the squeeze bottles. I generally don't recommend these. Like I said, they're very difficult for, I think, families to use. This is the Mead Johnson, and it uses a cross-cut nipple. And what you're doing, you're just squeezing the bottle like this. And if you do light pressure, only a little bit of milk comes out. If you do harder pressure, sorry, can you see? A lot more milk comes out. You can hear it. A lot comes out. And let's see. There are a bunch of different squeeze bottles on the market. I didn't even realize there were really that many. Apparently, I think people use them without having a cleft either. So I guess the most common ones for cleft that are the Mead Johnson and the Komotomo. When I was doing some research, I also found the green sprout silicone. There's also an InnoBaby Nursing Smart Silicone and Prince Lionheart silicone bottle. There's a bunch of them out there. So like I said, you squeeze the bottle for the flow. It can be difficult to consistently control how much pressure you're using, because I mean, it seems like maybe you're not squeezing a lot, and sometimes it seems like maybe a little bit's coming out, or it seems like a lot's coming out. It's really hard to tell. Like, I think you would have to practice with it not being in baby's mouth to kind of get the hang of it. It's tricky. And, you know, you're doing those 2 a.m. feedings with your newborn and falling asleep. You're not going to be doing a good job with this bottle. It's rough. You really need to closely monitor and squeeze only when the baby is sucking. Again, this is another bottle that a non-trained family member can't do. I wouldn't say just hand off to grandma or hand off to auntie, and anyone can give you a break and feed your baby with these bottles. The bottles really vary in price. The Mead Johnson is really cheap. It's like $3 a bottle. I think they get sold in like boxes of 6, and so it comes out to be very cheap. They do get pricier. The InnoBaby Nursing Smart Silicone, it goes up to like $25 a bottle. So there's a range. I think the Komotomo is like 12 or 15, I think. And yeah, it varies depending. I don't know, those other bottles I think are kind of like bougie bottles and just kind of a fancy, maybe trendy kind of thing for families. I forgot to include slides, I'm sorry. Once babies who have a cleft of the palate after their lip is repaired, they are still on the same feeding system. We don't have to worry about changing anything. But once they're getting ready for their palate repair, we do have a couple of surgeons who are more particular about what babies are taking. There is not a whole lot of research on non-restricted feedings after surgery. The different centers across the nation have different opinions on it. Some centers let you go completely unrestricted. They can go back on their bottle. They can have anything they want after a few days. And they don't have to have, I think, the no-nos. I think even some facilities don't make them wear the no-nos after their palate repair, but some facilities restrict. So you cannot go back on bottle after surgery. You cannot have just any food you want after surgery, and you have to wear the no-nos after surgery because they don't want anything going in their mouth. They don't want, the surgeons who believe in this, they don't want anything that's going to ruin the integrity of the stitches or make it possible for the sutures to come out. Like once they have their palate closed, they're able to get that intraoral pressure to suck. And I think there's a fear of them sucking the sutures open, the cleft back open. One of our surgeons is agreeable to letting them go back on the cleft bottle. He says because they're just compressing, he doesn't believe it's a problem. I think he doesn't want the nipple to go too far in, but he is okay with them doing the compression for the milk. Our other 2 surgeons feel a little bit more strongly about going to a cup after. So generally at about, depending on the age of the surgery, which can vary from 9 to 14 months, we'll start them on a cup, trying to get them ready to transition off the bottle. So usually at least 6 months, I'm telling parents to introduce a sippy cup or a little open cup. So we can do cups like this. This is just a Gerber Graduate sippy cup. It's got not a hard plastic spout. It's kind of silicone, but it's not like a nipple. It's still not something that they really compress on. It's just soft, I think, for their teeth or gums. What we would do is we would pop out the valve, and I really should have thought about that a little bit more. I didn't put water in these, sorry. And then we would just do like a little pour. This one doesn't have a vent hole, so once you tip it and the water comes out, not a whole lot will come out after that because there's no way for the air to vent back out. So you kind of just do sips, which is what we recommend for the little ones anyway, because the flow is going to be way faster than they're used to with their bottle. So when we're training families, we always tell them, just a little sip and tip it back. A sip and tip it back. Oh, I'm sorry. No-nos are the, it's like a bind, almost like a binder. It's got a Velcro, and it just keeps their arms stiff. So they're like little robots. They can't bring their arms to their mouths and get their hands and all up in their sutures. It's to protect them. So it's no to themselves. This is another sippy cup. This one is softer and it's got some slits in it. So when they're compressing it is when the milk comes out. I've had different views from the surgeons on this, because some surgeons are concerned that if they're doing this, then they're going to be sucking. But I kind of feel like once they're repaired, they feel like if they have something soft, they're going to try to suck from it. But I feel like pretty much anything, if they can suck, they may try. So we just have to kind of monitor and make sure that they're just doing sips at a time to kind of restrict, if they're really concerned about the sucking, to make sure that they're not going to be actively sucking on their cups. Other things that we use, if some babies if it's not a nipple, they do not want it in their mouth, so then we'll just go to cups. A lot of times for first-time users, I'll use just a little medicine cup. I like them because they're flexible, so you can kind of bend it to the shape of their mouth, so we know you can make it fit on their tiny little mouths. It's clear, so you can see when you're putting it to their mouth how much milk is flowing, so you're not drowning your baby. And then it's small, so if you have a big cup, you have to sit there and wait until the milk gets to the front of the mouth. And usually you're going slow because you're trying not to drown your baby. And it's hard for babies to wait that long, and they get impatient and they're just going to start thrashing around, and then you have milk everywhere. But if you use a little cup, it's going to tip forward really quickly, so you don't have to worry so much about the milk getting to their mouth in that amount of time. The other one that we will sometimes give families is the flexi cutout cup. You've probably seen these around. It's again another soft cup. It's smaller and it has a cutout for their nose, so they don't have to tip their head back. They don't have to tip their head back with this tiny one either. But if you're going to use a bigger cup like this, then you might have to tip your head back. And again, it's going to be a tiny little sip and tip it down. Let them swallow. Some babies do better when you keep the cup at their lip and they continue to kind of and help to swallow back. Some babies don't want it at their mouth, and you have to remove it before they'll close their lips and swallow. Let's see. Anything about cups? So after surgery, generally the day 0 to 3, the babies are going to be on clear liquids. And like I said, for a couple of the surgeons, they have to be completely off the bottle before they'll do surgery. So if it seems like they're nowhere near off the bottle, they're still doing like 4 or 5 ounces from the bottle 4 times a day, we might end up postponing the surgery unless the parents are like if they have the ability to and they're just stubborn little babies and refusing to take it, then and if the parents are comfortable with going cold turkey, sometimes we'll just go ahead with the surgery. And also if it's getting kind of later and we don't want to postpone it anymore. But sometimes we will, if it seems like they just are unable to take that volume, we will hold off on surgery. Day 0 to 3, they're on clears from their cups. After that, until day 8, they can go onto milk. So day 3 to day 8, they can go back on their formula or their breast milk. And then I think they get around 2 weeks, they'll get seen by the surgeon and get cleared for doing maybe baby foods, going back onto baby foods. And the reason they're waiting on going back to anything else is they really don't want anything going under the sutures that's gonna get stuck in there and maybe get infected. And also for the spoons, they don't want the spoons potentially going too far back and hurting the stitches either. Okay, sorry, moving along. I know we're running out of time probably. So we'll just kind of quickly go through speech development with cleft lip and palate. So babies without a cleft are capable of making vowel consonant sequences at about 4 months of age. So that's when you start seeing some babbling. And baby with cleft learn their early vocalizations without their typical oral structure. So their sounds come out being distorted and not how typical babies sound. Their impaired ability to direct the airstream orally generate, and they can't generate the sufficient oral air pressure. So just not having that partition, not having the palate intact makes it so they can't make most or some of these consonants when they're at this young age developing their speech. Um, babies with a history of cleft are challenged due to their anatomical constraints, and that can influence their vocalizations in several ways. So they may avoid palatal contact altogether instead of producing sounds that, and they'll go towards producing sounds that don't require contact. So you hear like the wa and the ma and the na and the ha, because that doesn't require their tongue to go towards their palate. They may have abnormal airflow, and that's going to impact their ability to produce enough intraoral pressure to get certain sounds correctly. So some other sounds might come out sounding more nasalized. So like they would say mamie instead of baby, I'm sorry, mamie instead of baby. And also they tend to have chronic middle ear issues. So these conductive hearing losses can impair their ability to hear their sounds correctly and to be able to produce them correctly. Generally, when they have their palate repaired at that 9 to 14 months of age, if we're noticing that they're having chronic middle ear issues, they usually get tubes placed at the same time. After the palate repair, the ENT will go in and also put in the tubes. All of these factors together can influence the sounds that the babies choose to produce and become integrated into their developing vocabularies, resulting in an expressive language delay. So because they're unable to produce certain sounds and they choose to do other sounds, they don't develop those words that do have those sounds, and so they'll have their delay. So common speech behaviors in children with a cleft lip and palate. Alveolar sounds typically do not emerge in babbling, which is typical at 6 months of age. So a lot of times you don't hear the t, d, n, and l sounds. The t, d, n, and l often don't emerge in babbling. They typically have fewer consonant sounds. They don't have as much variety. They have a smaller phonemic inventory, if you will. The early consonant inventory usually includes low pressure sounds. So they might have the ha, wa, and ya. And then they also might include glottal stops, which kind of sounds like an okina. And then also the vowel sounds. They might have some high pressure sounds. Oh, I'm sorry, the high pressure sounds are more difficult and they usually emerge later or are absent. So the sounds like k, ga, ra, and cha and sh are sounds that are more difficult for them. So sometimes you don't even see those develop at all. So glottal stops, like I said, glottal stops usually or can persist until about typically about 6 months of age. But glottal stops can be used in place of palatal or back sounds, and they'll persist in children with cleft. So you'll hear instead of saying cookie, they might say "ee." So they're dropping their backing sounds and they're doing a glottal sound instead. So some of these errors are produced in order to compensate for their structural differences. Also, maybe they might do a pharyngeal fricative, or they might do like an H substitution instead of like a sh sound, they might go like a sound. Again, they're compensating for their structural differences. They might have phoneme-specific nasal air emissions. So you might hear them say hun. They're pushing air out of the nose instead of producing an S. And you're hearing it only on certain sounds, maybe just only on S or S and C. They've kind of learned to compensate for their structural differences and they're producing it that way. So the different speech errors are kind of starting to get into it. We have learned errors versus obligatory errors. Learned errors are compensatory errors. They're maladaptive. Placement errors, they're learning nasal air direction, nasal air emission, and these type of errors are typically responsive to speech therapy, and they, if we work on them within therapy, they should be able to fix them. Obligatory errors are, compensatory errors, they should be responsive to speech therapy as when their structure is fixed. So if they're compensating because their structure hasn't been fixed yet, then they won't be able to do it. But once they've had their surgery and sometimes they still continue to compensate, they've learned how to produce the sound that way and they're still trying to overcompensate, then we need to teach them the right placement and teach them the right airflow to direct so that they're able to produce those sounds correctly. And so those are the things like the pharyngeal fricatives and the nasal air emissions and the glottal stops. Obligatory errors are due to a structural anomaly, and it's not due just to their articulation, not due just to their placement. So these type of errors do require medical management. They do need surgery to fix before they're able to produce the sounds correctly. Some of the compensatory errors for VPI include glottal stops. For glottal stops, the vocal cords adduct and then open suddenly, and they make a voiced plosive sound. It sounds kind of like a grunt, and it can be co-articulated with the oral sounds. Pharyngeal plosives, the base of the tongue articulates against the posterior pharyngeal wall, and this usually is substituted for velar sounds, so your K and your G sounds. Glottal fricatives, the air is forced through the glottis to produce an H sound, a sound. Pharyngeal fricatives, the tongue is retracted, so the base of the tongue approximates against your pharyngeal wall, and the friction sound occurs when air is forced through that small opening between the base of your tongue and your pharyngeal wall. The airstream is released through the pharyngeal port, resulting in a nasal air emission. Posterior nasal fricatives, the back of the tongue articulates against your velum, against your soft palate, as in like an ing placement. Air pressure builds in the pharynx and is released through your velopharyngeal valve. It results in kind of a large forcible inspiration through the nose. Oh, I'm sorry, a bubbly sound. It results in a large bubbly sound, kind of similar to a nasal rustle. And then a nasal sniff is when you're forcibly doing an inspiration through your nose. And it's usually for sibilant sounds such as your S in the final word position. Okay. I don't think we need to go through, I'm not sure if we really need to go through all of these sounds, yeah. Obligatory errors, so these are sounds that you'll hear when it's structurally based, so you'll hear them have a hypernasal voice, which is when too much air is resonating inside of their nose. So you kind of sound like Fran Drescher. She just has like a really high pitch, like kind of, I can't do it right now because I'm sick. I have the opposite problem, but your voice is going to come out very nasally sounding like Fran Drescher. Nasal emissions, so that's when a lot of your sounds are coming out your nose. You just, and it's not just S, it's not just SH, it's, you're going to hear it on a lot of your sounds. It can be co-articulated with some of your other sounds. So like you might hear it even with like a B. You're going to hear like a little puff of air come out of their nose when they're doing like a word like baby. Or you're going to have your nasalized plosives where it's not even a puff of air coming out of your nose. It's just turning it into a nasal sound. So your B's are going to turn into M's. Your N's are going to turn into C's. So you hear babies say like nanny for daddy. And they're not able to produce those plosive sounds. Am I forgetting anything? Ready? So Cecily's going to take over and talking about resonance.
So resonance, this is a little bit more speech specific, so I'll go over it kind of quickly. That slide just kind of shows you the different terms that we would use in our reports to describe the resonance. So hypernasality, meaning too much air through the nose. Hypo, meaning not enough, like when you have a cold. Mixed, there's some kids that will have sounds where there's too much air and then another sound is going to have not enough air. And it could just be an occlusion because of swollen tonsils or adenoids or extra fatty pad somewhere, or a nasal septum deviation. Cul-de-sac resonance is sometimes called potato in the mouth because it sounds like you have, sorry, the sound is there, but and it's resonating, but it's stuck. And so it's a little bit muffled and difficult to hear. Okay, so I'm going to kind of blow through the different descriptions of the resonance. You guys can ask us more questions about that if you want. The major structures for speech production. And then this is kind of some information on some of the different anatomies other than the palate that might affect the speech production. And then just generally that are different in these kids. So let me see. I'm going to skip through to just talk about occlusion. There's some sounds that are not going to be articulated correctly because of their occlusion. So how their teeth are aligned, how their jaw is aligned, and they're just not going to be able to get their tongue in the right place. This is just a quick ankle gosha. Lots of people like to say that if a kid's having trouble with eating or talking, that they maybe need to get their frenulum clipped. It's most often not the case. You don't need to move your tongue quite that far to make certain sounds. So sometimes clipping the frenulum can be more detrimental than useful. We can talk about that more later if you guys really want to. We won't go into that. So speech therapy, I know that the focus of EI is a little bit more, is not so much on the speech production, but just as some information. Articulation, speech therapy for these kids with cleft, with errors because of their cleft palate, they're not that scary. I mean, they sound a little bit different, but you're working on placement, and so that's, you know, just traditional speech therapy with focus on the placement and just being realistic about what sounds are appropriate for them to attempt at that age. And it just takes a lot of practice. You're, you know, reworking an old habit, and that can take time to get through. All right, just want to make sure I'm touching on stuff that's important. Okay, I'm gonna let you guys look at those and say if you're not. Jamie did a nice job of talking about when therapy is not effective. So just think about obligatory errors, things that are happening even when they're getting the right placement with their mouth. And then I think just one thing to note, I know that, like I said earlier, I know that the focus of early intervention is not on the speech production, but it does help for the patient, the child, to work on the right placement even as early as before 3, because it does give us more opportunity to evaluate their speech at its best. And we would like them to get a secondary surgery if they need one as soon as possible to give them the best chance and the earliest chance to start working on their speech sounds, so that they, you know, have lots more time to work on the sound and less time producing a sound that's not what we're looking for. So, you know, working on getting them to see where your lips are moving, how your lips are moving, where your tongue is going, and encouraging the families to model those placements for those speech sounds. That gives the child more information about what kind of movements they should be making for speech sounds. And then if they're able to be more consistent, it gives us more information to evaluate them on so that we can make better recommendations. Let's see. I don't know if there's any questions. This slide gives you Jamie's and my contact information. And if you have any questions about what to expect about the kids that you're working with. A while back, someone mentioned to me that they were afraid to call us because they thought they had to pay to talk with us over the phone. Just for the record, that's not true. Although we do need to stay productive, we do also encourage people to call us and talk to us about what's going on, because sometimes we can't get the patients in for therapy with us, and so we really need your support. And if you have questions, we would like to answer them so that we can get them the best help, and so that everybody that's got their hands in this child's care are all on the same page. But that's how you get in touch with us. Okay.
We have one question. How do we find out about the recommended, what you have recommended for bottles? Is it coming from the big island? We typically don't hear much from the families following their KCCC appointment.
So generally, the families, they'll have their bottles, the ones that they're using. Sometimes if they were born at this hospital, and maybe if the baby was struggling a little bit, they might have discharged with a couple of bottles. Usually if we try one, and we can't do anything else once we've given it once the baby's used it. So we tell them to take it home with them anyway, just so that they have it if, you know, the bottle that we discharge them with like the baby goes home drinking on Dr. Brown's, but they had also discharged, had trialed a Haberman maybe, or the Medela. We tell them go home with both of them and keep it because maybe that one might work better for you later. Don't throw it away because we can't do anything with it anyway. But we do tell them which one that they should be using, and so they should know which bottle they're on. If you guys have any question about it, usually I feel like it's in the doctor's note, like what bottle.
Yeah. At each Cleft appointment, they will eventually get sent home a summary of what was discussed, and that usually has the recommendations from all of the providers, speech doctors, audiology, and that gets sent home to them. The parents can always request for the reports and the charting to be sent to them, and then they can share that with you. And then if you want a more direct line to one of us, then if we didn't already have a consent form signed, then if you want to speak with one of us, it's easy to just have a consent form signed on your end since the parents are with you, and then just fax it or email it to us so that we can have it on record, and then that way we can have an open conversation about the recommendations and the findings.
But if you do notice a parent that is feeding the baby and seems to be the baby is struggling with it at all, or if you see a baby with a cleft who's drinking out of a regular bottle, I would ask them about it. We have had a couple of families kind of go rogue on us. Like we recommended a cleft bottle, and they start off using the cleft bottle, but they think, oh, my baby doesn't need this, so they just give a regular bottle. And then the feedings end up taking an hour, which is not, appropriate. We want the feedings to be 30 minutes or less. So if they're like, oh yeah, they can take the regular bottle, it just takes longer. But that's not okay for them to feed that long. Then, I would definitely ask them about it and, kind of make sure that that's what was recommended, or, were they just trying it on their own and, oh, look, it's taking a really long time. Maybe you should switch back to the cleft one. Because some families really just, I don't know what it is. Because it's a lot of time, even the families who aren't paying for the bottles, it's not like they have to worry about buying the supplies, but I don't know if it just makes them feel uncomfortable that they have to use a special bottle. But yes, yeah, we definitely want the babies to be safe, and we want them to gain weight. And if they're feeding for over 30 minutes, they're going to start burning calories, and that's not going to be helpful. The other thing is we also have families who try to alter their bottles. They'll say, oh, they're having a hard time with it, so I'm just going to cut that nipple, and they're finishing their bottle in 5 minutes. I'm like, that's not okay either. If you see the babies with lots of milk coming out of their nose, they're sounding really congested, it's a problem. They should not be feeding that way. I've had parents come to me who've said that other providers have told them, oh, your baby has a cleft, they're gonna be a noisy feeder. And that's not necessarily true. We have quiet feeders. All babies with clefts are not gonna be noisy, congested sounding feeders. They can feed quietly if they have an appropriate bottle system. Yeah. Okay. Very good. All right, thank you so much for joining us. I hope this was helpful. If you have questions, please feel free to call us. Thank you.